Hello, good morning. I'm so glad to see those who are here and welcome those online. My name is Erika Saunders. I am a psychiatrist. I am a professor and chair at the Penn State College of Medicine and Penn State Health. And my area of specialty and particular interest for my own personal practice, research, and education is in mood disorders, depression and bipolar disorder. So today, what I'd like to talk to you about is depression and bipolar disorder. I titled it The Moody Blues, How to Paint a Brighter Picture. So we're going to talk about what is mood, why do we have moods, what does it mean when we have a mood disorder, what does that mean, what does it entail, and most importantly, how can we help people who do have difficulty with mood. So I'm starting with a quote from Dr. Kay Jamison. And I'll read the quote and then I'll tell you about Kay. There's a particular kind of pain, elation, loneliness, and terror involved in this kind of madness. You are irritable, angry, frightened, uncontrollable. What did I do? Why? And most hauntingly, when will it happen again? Which of my feelings are real? Which of the me's is me? And what is the reality of any feeling? So Dr. Jamison writes this both from professional and personal experience. So she is a psychologist, a very renowned psychologist, specializing in bipolar disorder, but she also has experienced bipolar disorder herself, and she wrote about this in a book called An Unquiet Mind. And reading of her experience and reading of the experience of other individuals who have mood disorders, I think is really, really important to understand truly what is going on. And this quote emphasizes that when I'm talking about the things that we'll talk about today, it's very unsettling. And so even after an individual feels better and feels well, it's an unsettling experience. And so that's part of how we have to help folks down the road. So what is a mood disorder? First of all, what is mood? So mood is how we feel. It's generated by the limbic system in the brain. These are fundamental emotions, happy, sad, and it's sort of, I describe it as when you get up in the morning and how do you first feel? And so we all have mood. Moods are good to have because we want to feel good when something good happens. We need to feel bad when something bad happens. We need to feel the full spectrum of emotions because that's how we make our best decisions. If you don't feel bad when something bad happens, then you may not respond and react appropriately and change something in the environment. So mood reactivity is really adaptive and really important. However, what happens in a mood disorder is the mood gets stuck outside of this normal range where it can go up and down. And so I'm depicting this here for major depressive disorder as being below that dotted line. And it can be a little bit below the dotted line, it can be a lot below the dotted line, and that is how mood can get stuck, both in terms of severity and time outside of that range. So major depressive disorder, we'll talk about the particular symptoms that are involved, but it's generally low mood, low symptoms. Bipolar disorder includes both low mood, below that dotted line, excessive sadness, etc., but also elevated mood above that dotted line, and we'll talk about what that means. Bipolar disorder type 1 tends to have very extreme swings of mood, and bipolar disorder type 2 tends to have less extreme on the high side, but maybe more prolonged periods of time with depression. So these are some of the patterns that we can see of when mood gets outside of that normal range, what can happen. A depressive episode. So what is a depressive episode? It's generally when the mood is down, depressed, or what we call anhedonic, which means that there's no enjoyment in things. You go through the motions day to day, but you may not feel those sparks of enjoyment. The symptoms listed here also include what we call the vegetative symptoms of depression, which is changes in sleep, changes in energy, changes in appetite. All of those can be affected. Sleep can be too much or too little. Appetite can be too much or too little. People with depression often have a loss of interest in usual activities, often feelings of guilt or worthlessness that are very much out of proportion to any sort of external environment or trigger. A decrease in concentration, decrease in, it could be a decrease or an increase in movement, which are what we call psychomotor disturbance, which is like fidgetiness or restlessness or slowed movements, and then thoughts of suicide, which very unfortunately are part of the illness of depression. There are a lot of different things that can mimic depression, so when we do an evaluation for somebody who might have a depression, we're always checking for thyroid abnormalities, blood counts, and then some of the more less common illnesses, seizures, Parkinson's disorder, vitamin deficiencies, some of the infectious illnesses, and other psychiatric illnesses as well. The manic side of bipolar disorder is a separate type of mood state. So this is characterized classically by elevated mood. Typically this is a euphoric mood, a happy mood. However, over the past 30 to 40 years, with a lot of research and study, found that it's not just elevated or happy mood, but also irritated mood and high energy that really characterize a manic state. So this is way above, think of the happiest day that you may have ever had. A manic episode would be above and beyond that and would be out of proportion to what's going on and be viewed as excessive by the individual themselves and people around them. Tends to go along with distractibility, severe distractibility, severe impulsivity that may cause quite a bit of trouble, often in financial and other impulsive areas. Grandiosity, meaning that people think that they can do things that other people couldn't do or that they can't do normally. This can get very out of proportion to reality. Flight of ideas, and flight of ideas is where the thoughts go so fast that you can't really catch up to them. So as opposed to in depression, where the thoughts are usually going very, very slowly, and it's hard to think and it's hard to communicate, in mania, the thoughts are tripping along, sometimes so fast that it's hard for the person to articulate in a coherent way. Activity is really increased. This is a core feature. It's often physical activity, but it's physical and mental. There's a decreased need for sleep. So as opposed to insomnia, let's talk for a minute about insomnia. Insomnia is really common. We can get insomnia for a lot of different reasons, and that just means a difficult time with having a restful sleep. You could be sleeping the same number of hours that you would sleep normally, but just not feel rested because of the type of sleep that you're getting, or maybe you had too much caffeine or alcohol or too much excitement. All sorts of things can disrupt our sleep, and that's really, really common. That's more like the type of insomnia that happens in depression. What happens in mania is that there's actually a physiologically decreased need for sleep in the brain. So people have 0 to 4 or 5 hours of sleep and do not feel tired for days or weeks, or sadly sometimes months at a time. This is not a normal physiological state, and that's the distinction in mania and hypomania with the decreased need for sleep. Talkativeness is often also part of mania. Talking too fast, talking too much, interrupting, feeling this very strong drive for speaking, which goes along with this high energy state. So that's what I'm depicting in these graphs when I'm talking about the mood above that line. So there are a number of things that can mimic mania. Again, thyroid disease, Thyroid disease is really common. We screen for it a lot, and it can cause all sorts of mood and anxiety problems. Other endocrine diseases like Cushing's disease, which is a disease of cortisol, a number of neurological problems, seizure, multiple sclerosis, lupus. So a number of things that affect the brain, and I'll talk more about how the brain produces mood in a bit. And a number of other psychiatric illnesses can mimic mania as well. Okay, just a couple more facts about these two different states before we move on to some other information. What's the difference between hypomania and mania? It's really a difference of time and severity. This is the difference if you've heard of bipolar 2 disorder and bipolar 1 disorder. This is the difference between the two. Hypomania tends to be shorter or less severe. Actually, it doesn't have to be impairing. Sometimes people, when they have a very mild hypomanic state, they feel better, they feel more energized, they're doing more, and it may not be impairing to their life. What tends to happen, though, is that they experience depressions that are very impairing and difficult to treat. And if it's not understood that that's happening in the context of a bipolar disorder, there's a different treatment to major depressive disorder. With any of the things I'm talking about today, we are really looking for, from the perspective of intervention and treatment, we're looking for the fact that this has impaired someone's functioning. So that's really when treatment is needed, is when someone's not able to function at home, has difficulty with relationships, jobs, education, and the like. And I talk about the need for sleep. Just a mention about psychosis. So psychosis can be a part of any of the mood disorders. It's rarer in any of these mood disorders, but psychosis is basically a detachment from reality. It's a brain state. We're learning more every day about what happens in the brain to cause this. It's basically a misfiring and a misconnection of different parts of the brain. And so what happens is the brain associates things in ways that aren't connected to what's actually going on. It's often very frightening for the individual and for those around them. There are very good treatments for this. So that is things like delusions, which are thinking things that aren't true, not based in fact, or having experiences, which we call hallucinations, that aren't based in sensory experiences. So it's hearing, seeing, tasting, smelling, or feeling something that doesn't have a sensory trigger. So we have these senses. The senses are normally detecting what's in our environment, but when these misfirings happen, you're getting those sensory experiences without that trigger. So that's what psychosis is. So when people have a mood disorder, the mood can be in one of these extreme states for long periods of time. But through this, I'm just depicting some work that we did looking at day-to-day mood for people who have bipolar disorder, who are out and about in their normal lives, generally not very symptomatic from a medical perspective. They were in a treatment trial that we were doing to try to find a better way of controlling mood long-term in addition to medication, so we could reduce the amount of medication used, and we were testing a particular dietary intervention. So we were measuring mood twice a day using smartphones, which would just ping at various times a day. We would ask, how's your mood? 1 to 100. And in that bar, 40 to 60, that's what we've told these folks, that bar means that's sort of the normal mood variation range that I was talking about before. So what you can see here is that even people with bipolar disorder who are on medications and doing fairly well still have a lot of ups and downs in their mood. And so one of the things my research group is really focused on is how can we help that over time and how does this affect people day to day.
Question.
Yes.
So the vertical axis there is a self-evaluation level?
Yes. Yeah, exactly. 0 to 100, how is your mood? 0 to 100. And on the x-axis is the days.
Yeah.
Over time. Yeah. So again, that's just to say that this is the brain's driving mood outside of that normal range. And so the goal is through various ways, and I'll talk about what the treatments are, different types of treatments, is to lessen that variability over time. And that leads to better overall health. The impact of mood disorders. So bipolar disorder occurs at about 1 to 2% of the population. Major depressive disorder occurs in about 20% of people over the lifetime, and about 6% of people have a serious major depressive disorder. So it's a leading cause of disability, and in this graph is the global burden of disease figure, showing the whole box shows all of the years of life lived with disability. And so the size of the box is the impact of that particular illness on disability. And so you can see depression and bipolar disorder have big boxes. Early treatment can prevent recurrent episodes, morbidity, etc. So what I've been talking to you about are what we call the syndromic part of bipolar disorder and depression. And that means it's a collection of symptoms that happen together. It's been recognized throughout history. Since the Egyptians, the ancient Greeks described it basically the same way I just described to you what depression and bipolar disorder are. Over the years, it's also been called manic depression. And so historically, it's been a condition experienced throughout history. And the syndrome is those collection of symptoms. We know that biology affects these syndromes, but so does environment. And so we'll talk a little bit about that. I'm going to talk about a couple of specific examples of how mood disorders may differ in men and women. In women, there can be a hormonal component with reproductive hormones, in men too, but especially in women, to triggering episodes or impacting these illnesses. So we know that postpartum blues is very common. So when women have babies, there's a few days where many women can feel down, low, and not really like doing much of anything except caring for the baby. This may be of evolutionary advantage because it keeps women, if you think about times when going out of the home was very dangerous, it may have been an evolutionarily protective factor to keep women and infants in the home during that vulnerable time. That's one theory. Postpartum depression is commented about 10 to 15%. And that's when that depressive syndrome happens after the birth of a baby. In that, generally it happens within 4 to 8 weeks, but it could be any time in that first year. And when it becomes impairing is when we call it postpartum depression. Postpartum psychosis or bipolar disorder. For women who have bipolar disorder, an episode in that postpartum or peripartum time is very common. But a new onset postpartum psychosis is uncommon, about 0.1%, but very important to recognize and treat. Premenstrual dysphoric disorder and postmenopausal changes are also extremely common for women who have hormonal sensitivity to their illness. And needs to be recognized and treated in combination with good treatment for women's health. We also know that people with bipolar disorder and depression, women with bipolar disorder and depression also have more common comorbidity with anxiety disorders, eating disorders, migraine, insomnia, which are more common in women in general. Mood disorders in men may present a little bit differently than in women. Much of what I've talked about in general is low mood, elevated mood. So some of these symptoms can present differently in men. High rates of anger attacks or aggression, substance use as a mask to the difficult experiences of depression, and risk-taking behaviors. So we have, I think we know scientifically that mood disorders are undetected in men. And so the field is talking more about how to make sure that we're recognizing and treating appropriately, because the tradition, if you just ask about sadness, you may not be detecting every man who has a problem. Testosterone and depression has been an area of interest and wonder for the field. Does testosterone affect mood? Depression, testosterone affects a lot of things. And while we do think that testosterone affects mood, treatment trials of testosterone to treat depression have not been effective. So there's a complex interplay there, whereas we always advocate for good general health. Taking exogenous testosterone specifically to treat depression is not likely to address the complete problem. Later in life, depression can come on later in life. The general age of onset for both major depressive disorder and bipolar disorders is in the teen years. That is the highest risk time period for an onset of illness, but there's a second peak later in life. And it's important to recognize that it's not a normal part of aging. Everybody who gets old, and I'm just telling you what other people have said to me. If I'm old, I'm going to get depressed. Not true. If I have cancer, I'm going to get depressed. Not true. If I have bad heart disease, I'm going to get depressed. Not true. It is definitely not a normal part of these other illnesses. It's often it's common, but that doesn't mean that treatment won't help. So one thing I'd love for you to take away from this is that message. It's not a normal part of aging. It's not a normal part of grief. So grief is a very profound reaction to terrible things that happen in life. And you can have many of the same experiences and feelings and emotions and sleep disturbances and appetite disturbances that I've talked about with depression. But depression is distinct from grief. Grief can go into depression, but we need to recognize that they're not the same thing. Because when grief becomes depression, it goes beyond the adaptive phase of grief, and you have things like that excessive guilt and worthlessness that I was talking about. You may have excessive hopelessness, thoughts of death or suicide. All of those things would indicate that a grief has gone beyond to depression. We do want to be very attuned to depression later in life, because this is a high-risk time, especially if someone has little community about, not very much community about them or family. It can be a very high-risk time for suicide. So just little tiny bit of biology here. Depression and bipolar disorder are disorders of mood. The mood comes from the limbic system. So if you see in that upper right-hand corner, there's a brain with a blue curvy bit, and the little red things at the bottom are the amygdala and the nucleus accumbens, part of what generates emotion in the brain. That blue thing is part of the hippocampus, which is part of the brain that helps consolidate memory, among other things. Memory can be very much affected in depression and bipolar disorder. And the red part at the front, prefrontal cortex, is part of the brain that helps us do reasoning and thinking and planning and make decisions. So one of the things that happens in depression and bipolar disorder is those two parts of the brain don't talk to each other as well as they should. And that's really important when we get to some of the treatments. On the left hand of the slide, you see the names of some of the main neurotransmitters in the brain. The neurotransmitters are the chemicals that help the brain cells talk to each other. So serotonin, norepinephrine. Serotonin is involved in mood, pain, sleep, appetite, lots of different things. Norepinephrine is our fight or flight hormone. So when you get really scared, if you watch a horror movie on Halloween, you're activating, among other things, the fight or flight response there. Dopamine is the neurotransmitter that helps us with that sensation of reward and wanting to go out and find new things and get new things. And that helps us direct our attention as well. Glutamate is an excitatory neurotransmitter, and GABA is a calming neurotransmitter. The medications that we give for depression and bipolar disorder affect all of these things. Other hormonal systems are involved. I've mentioned thyroid a couple times, reproductive system we've talked about. The circadian rhythm system is the system in the brain that helps our brain figure out when to sleep, when to eat, when to be active, when to be restful. And that is a system that we know is somewhat disturbed in both depression and bipolar disorder. We think particularly for bipolar disorder that there is there could be a fundamental difference in that system for those individuals who end up having bipolar disorder, because it tends to be much more difficult to keep a regular schedule for those individuals. And I've talked about how sleep is involved in both of those illnesses. The mitochondria are the energy generating parts of our biology and our cells at the cellular level. The mitochondria produce energy. There are some mitochondrial illnesses that are very severe and cause really severe developmental problems, both at birth or later on in life. And while that, and some of those illnesses have a much higher rate of depression and bipolar disorder and schizophrenia, the psychotic illness, we are finding that in people with bipolar disorder and depression, there are mitochondrial differences that are subtle. But that might be behind some of the energy differences that we see in these, in both depression and mania. And inflammation might be something that's driving these biological changes. So risk factors for mood disorders. There are some things on the right-hand side of the slide that we cannot change. Some of these, depression and bipolar disorder has an element of genetic risk that is generational and comes in families. There are hundreds of genes involved, so it is, and there's no genetic test for depression or bipolar disorder, but we know that it can run in families. Early life stress or mistreatment can be a risk. Stressful life events can be a trigger, and medical illness can absolutely be a trigger. So we think of it that people have a predisposition, we all have a genetic predisposition to something, and some people have a genetic predisposition to mood disorders. Then other events happen, and that can trigger illness. Some things on the left are modifiable. Some misaligned coping styles. We all cope with stress and cope with the world in different ways, and sometimes the way that we learned how to cope with stress at maybe early in our life isn't working so well for us now. And that's something that we can address in psychotherapy, and that can be changed. Drug and alcohol misuse can certainly worsen depression and bipolar disorder. Again, something that can be helped and treated. I talked about grief before, paying attention to what our needs are and the needs of our neighbors and family and friends and community are in grief is really important in terms of preventing a depression. Seasonal reaction, sometimes people feel better or worse in different seasons. There's likely, back to the circadian rhythm system, there's likely some biology behind this. But we each have our own pattern for how we react in the seasons. When it gets about this time of year, at about 6 o'clock at night, I'm bundling up in a blanket and trying not to go to the refrigerator too much and thinking about bed. So, so it's good to know about that and think about that in terms of some of the things that I'll talk about in terms of, how to help. And then reaction to stress. Stress happens for all sorts of reasons. There's nothing we can do about, well, we need to recognize the boundaries between what we can do and what we can't do. That's really important. So there are things that you can control your own reaction to a stressor that happens, but you may not be able to change that external stressor. And so that can be really important. So I'll just give you an example. Let me think. So if you think about a youth in college, so maybe that person has been told for family reasons that they should go into engineering. They don't want to go into engineering. They want to study history. If you feel that you're in a situation where you're stuck and you don't want to do something, or you can't do something well, and you feel stuck in that situation, that is a vulnerability for a depressive episode, for example. All right, now let's talk about resilience and treatment. So I've talked about a lot of really bad and scary things. But the good news is that there's a lot that can be done to help. And so resilience in mood disorders looks a lot like resilience in life for everybody. And so these are certainly things that I promote for people regardless of mood disorder or not, but especially important for those with mood disorders. Having a routine every day is really, really important. It's good biologically. It's good for those hormonal systems that I talked about. So going to bed at approximately the same time each night, getting up at approximately the same time each day, eating at about the same times of day. Exercise is good for everything in the body and the brain. And having some time outside or some light, which can be a problem this time of year. Having a good social network and checking in with your social network is important. We're not all extroverts. I'm not. I am an introvert for sure. Right? So not everyone likes to have the same type of social network or same type of social interactions. But in general, we as a species are very social beings. And so it's important to have people that you trust, that you can check in with, and people who can tell you if they're worried about you for some reason. That's really, really important. Finding sources of contentment and joy is also really, really important. We can all get into times and periods of our life where, for whatever reason, we've lost the time, the energy, the means, whatever, to do things that we love and enjoy, and that can be really challenging. And getting back to finding that joy is really important. And using some techniques to check mental habits. So anxiety is hardwired in the human brain. We all have anxieties, and learning how to address that and how to cope with anxiety is really important. So I put some icons on the screen. Sunshine, just depicting getting out there, doing fun things. Any type of meditative practice, whether it be prayer, meditation in any one of the number of meditative traditions. For some people, exercise also functions as this sort of meditative state. Practicing any of the arts or any of those practices are very, very helpful for prevention of anxiety and for just calming the nervous system and sort of checking in with that contentment and joy part of life. Gardening. I put the flower up there because I love to garden. All right, safety first. So what to do in a crisis. So when people have these highs and lows that I've been talking about, depressive and manic episodes, things can come to a crisis. So thoughts of death, suicide, impulsivity can lead to crises. And it's an unfortunate part of the illness, but something that's very important to recognize, and something that can be really, where friends and family can be really, really helpful. So the first thing is for that social network to help the person and recognize that there's a crisis and help that person. So just being there, doesn't matter if you know what to say. You don't have to know what to say. It's okay. Just be there, show the person that you care, and show them that you'll be with them through this. That often provides a lot of hope. Even little things can be comforting during this time. So reminders to eat, to just have a little bit of quiet time. Anything comforting can be comforting music, that sort of thing. Providing hope and assurance that better days are coming. So I'll talk about treatment. Treatment really does work. Getting someone to a provider that can help them is really important. Empathy is really important. However, I want to say that when someone is in a depressive state in particular, they themselves have lost that ability to hope. If it's very severe, that's one of the parts of the illness. It's a core problem. And when you're talking to somebody who is feeling that hopelessness, you yourself can start to feel hopeless because of the transfer of empathy. That's how empathy works. Empathy means I'm trying to feel how you're feeling, and in order to better connect with you. And so if you're trying to help somebody when they're in a severe depressive state, you yourself might feel hopeless. That's a normal part of empathy, first of all. And what I'd like to encourage you to do is sort of step out of that and think, okay, it's part of connecting with this person, but I know that there are a lot of different ways we can get help here and that there's a lot of hope. So part of the job of all of us who help people when they're in a depressive episode is to help provide that hope, that external hope. And I say to people, borrow my hope until you can feel it yourself. I have hope for you, and I will never give that up. We also want to make sure that we're, this is more for the medical side of things, treating in the least restrictive setting. We don't want people to need to go to the hospital when they don't have to, obviously, but sometimes that is the most safe and effective way for someone to get help. There's lots of different ways here in Pennsylvania to get help, and I've got that resource list at the end of this talk. Each county has a crisis center. They're there 24/7. So if you are ever worried about someone or worried about yourself, you can call the county crisis. They will talk you through what you're going through. There's the national hotline as well. Hospitals, trusted advisors, counselors, religious leaders, all can be helpful during this time. Okay, guiding principles of treatment. So first of all, treat what works. There's unfortunately no specific test for us to say which treatment is going to work best right away. We're not quite to that yet from a medical perspective, but we have lots of different kinds of treatment, and we can do a careful evaluation of all the factors that I've talked about and understand what is the most likely treatment to work. So what I've listed here for you is a few questions to ask if you're going in for treatment, things that you might want to know or your loved one might want to know. How does the treatment work? What should I expect to change? What part of the difficulty that I'm experiencing might get better? Hopefully most of it, but you want to know what the target is. How long will the change take? What should I avoid if I take this treatment? Different kinds of medications, over-the-counter treatments, sunlight. Some medications cause some sensitivity to sunlight, particular food or drink. What are the most common side effects? What are the most serious side effects? Is there any monitoring required, like blood tests? How long will I need to take this treatment? And what happens if I miss a dose or a treatment session, for example, if it's psychotherapy? So for depression and bipolar disorder, we treat with both medication and psychotherapy. So medications change the brain on a cellular level, and they last during treatment. And what I'm showing here in the pictures is some work that's been done to show how one medication actually helps parts of the brain grow. So parts of the brain are affected by depression and mania and get a little thin at that cortical or the outer level. And medications actually help that grow. So we can see at the cellular level the good things that are happening. In the bottom picture, depicting the connections between different parts of the brain. And on the left hand is what happens with medication, on the right hand is what happens with psychotherapy. So psychotherapy really helps the brain connect to each other, these different parts, because psychotherapy helps teach coping skills, teach ways of thinking and ways of perceiving stress and what's going on in the world, and that is also actually changing the brain in a good way. There are many, many different types of medications and therapy for depression and bipolar disorder. I've listed a few here just because you may have heard of them. I don't have time to talk about all of them in detail. Happy to answer questions if anyone has questions about them, but there are 5 and now even more different types of antidepressants. And for bipolar disorder, there's lithium, there's the anti-epileptic medications, which also help for bipolar disorder, antipsychotic medications, which is a terrible name, I wish they would rename that, because they're really medications that affect the dopamine system. They're dopamine modulating medications. And those medications are termed that because they were initially used for psychotic illness, but they're used for many more things. Bipolar disorder and bipolar depression does not respond to the same treatments that major depressive disorder does. So it is important to understand the difference and for a treatment provider to really be tuned into what the best treatments are from that perspective. There are a number of different and important psychotherapies that are evidence-based and helpful for people with depression and bipolar disorder. Now, psychotherapy used to have a reputation, maybe probably still does, have a reputation for lying on a couch and going weekly or more frequently for long periods of time. And I'd like you to take away from this today that that's not the state of psychotherapy today. So psychotherapies can be delivered in just a few sessions. They can be delivered in group settings as well as individually. We don't tend to use couches anymore. And oftentimes the treatment is a brief period of time, 4 to 12 weeks, with a distinct goal for treatment, and that you want that treatment response in that period of time. Sometimes longer-term treatments are helpful, and that's fine too. But brief psychotherapy is also important. Psychotherapies can focus on mindfulness, which is that skill of being present and not letting anxiety drag you into the what-ifs of the future or the regrets of the past. Psychoeducation is really understanding what's going on with the symptoms and the illness that an individual is going through, and how an individual or a family system can really deal with that. Family-based therapy gets also into some of the complexities of the relationships between family members and how that can be strengthened. Cognitive behavioral therapy is really all about what is our mindset. We all have particular ways that we look at the world for various reasons based on history and what we've been through. And is that adaptive for what we're going through now? And if not, how can we change that? And then interpersonal therapy is all about how do I interact with other people around me, and is that a beneficial way of interacting, or is there something that can be improved? There are other treatments that you might have heard about because they're in the news a lot. So in the past 20 years, but really in the past 10 years, there are a number of medication treatments that have been found to provide rapid relief for depression. So ketamine or S-ketamine. S-ketamine is a chemical, not a chemical modification, but a chemical refinement of ketamine. Ketamine is an anesthetic medication that's been used for years and years, decades, and more to cause people to be able to tolerate pain or traumatic pain. So if you give ketamine in high doses, it causes a state where you're not really aware of what's going on and you don't remember things as well. And so if you're in a car accident and you get a dose of ketamine, it might be helpful for you to get through that trauma. However, in low doses, it was found to be helpful for certain types of depression, severe depression, and helpful in sort of a 24-hour period, which is really exciting. The problem is that benefit doesn't tend to last. And so the field is still grappling with how to make sure that someone who gets better on any of the rapid treatments can stay well for long periods of time. So ketamine treatment is out there. There are ketamine treatments that are provided by reputable treatment providers who have knowledge about psychiatric illness and depression. There are also clinics, because ketamine is an FDA-approved medication, that are doing this without the proper, not in the proper way. So just know that. S-ketamine is a nasal treatment that was a nasal spray. Ketamine's IV. S-ketamine is a nasal spray that can also be used to treat depression and in that rapid way. The psychedelic medications, which you may have heard about, are also being tested for rapid treatment of depression. These are all experimental. And so there's nothing that is out in FDA-approved use from the psychedelic perspective for depression and bipolar disorder. Scopolamine is an old medication used for lots of different things. There was a rapid treatment effect found for depression, but for many reasons it's not a great medication to be used on a regular basis, and so we don't use that clinically. On the device side, there's lots of different things. So digital therapies are apps that can help treat depression. There are a lot of them out there. There's only one that's FDA approved for treatment of depression. And so most of them use the therapy techniques that I was talking about before and help reinforce those. So just be careful, because there's a lot of things out there and they're not all helpful. Light therapy is depicted up in that first picture. The woman is looking at her maybe daybook or calendar, and there's a light box in front of her. Light therapy helps reset that circadian rhythm and keep our body and our brains in tune with day-to-day rhythms. It's a good treatment. It can be very helpful for depression. There are a couple of things then on those bullets: transcranial magnetic stimulation vagus nerve stimulation, and electroconvulsive therapy. These are treatments that are done when people have not responded to medication or can't take medication. So these are treatments that are very effective, but much more rare. Transcranial magnetic stimulation uses a magnet. You can see the wand over the person's head to stimulate parts of the brain. Vagus nerve stimulation is an implantable device, like a pacemaker, that can stimulate the vagus nerve and be effective. And electroconvulsive therapy uses electricity to affect different parts of the brain. All very safe, all can be effective, but should be used in certain select situations. Deep brain stimulation, which can be used very well for Parkinson's disease and tremor, is experimental for depression at this time. So how do you get help? I wanted to talk a little bit about the healthcare system as a whole, because this can be really complicated to try to figure out how to get help. So first of all, your primary care office may have integrated mental health care. That's something that many health systems are doing and many primary care offices are doing. And so if you or a loved one needs mental health care, that might be the first place to ask. And that's often to be provided in a quick way, and sort of understand the situation and figure out what's needed right now. It might be a longer-term treatment. It may be a referral to a longer-term treatment. Psychotherapy. There are lots of different types of providers. There are several different types of providers that can provide psychotherapy. So you may hear the terms licensed social worker, licensed psychotherapist, psychologist, psychiatrists. All of these providers can do psychotherapy. And psychiatrists tend to have either a general practice or sometimes a specialty practice that might be of interest for a particular type of problem. I then have a list of resources of books and websites that might be helpful. So these are some books, both first person accounts, like The Unquiet Mind by Kay Jamison, The Noonday Demon by Andrew Solomon, are first person accounts of what they've particularly been through. There are other books on this list that are more guides to how to get help or how to deal with bipolar disorder or depression, like the Bipolar Disorder Survival Guide, Bipolar Disorder, a Guide for Patients and Families. On the bottom, the Feeling Good Handbook is a book by David Burns that is based in cognitive behavioral therapy. It's the basics of cognitive behavioral therapy, an excellent book. And The 7 Principles for Making Marriage Work by John Gottman. I'm a big fan of this book. The Gottmans did decades of research into marriage and families and relationships and what can help strengthen relationships. I mentioned that our crisis resources are fairly rich in Pennsylvania. So we've got the 988 number, which is a national number. You can actually call or text or get a chat online with the 988 folks for suicide prevention or crisis prevention. There's also a crisis text line, texting 741-741. Dauphin County Crisis Intervention number is there. Each of the counties do have their own crisis intervention services. The YWCA, both in Harrisburg and Lancaster, has services for various types of trauma work. There's the Trevor Lifeline and the Veterans Crisis Lifeline as well. I put a few online websites for crisis resources as well. If you can't see these, I'm happy to send them out to anyone who's interested. So I'll summarize by saying treatment really does work. These are treatable illnesses. It feels when you're going through it like it's the end of the world. It really does. And that is part of the illness. One of the things that drew me into this work was the fact that there can be such an improvement in terms of what people are experiencing. The goal is to help people get back to their normal life, what they want to do, whatever it is that they want to do, interacting with their families, etc. So I use pictures by Van Gogh, who himself suffered. I really do think that there's a brighter day. And so that's the most important thing to convey to people with depression and bipolar disorder and their families. So thank you. I'm happy to take any questions. Yes, Jack.
Quick comment. We go to a Penn State primary care office, and they always, no matter why you're there, they give you a little questionnaire about mental health. So they actually take care of that situation. Question, in today's world with the internet, and particularly with teenagers, there seems to be in the news an effect of the internet and social networking through the internet, and teens in particular, and a lot of teens are not getting out of the house and doing sports and things like that because they really get addicted to being on the internet all the time. What effect does that have on mental health?
Oh, great question. Yes. So the internet is designed to capture your attention, and there's a lot of psychology behind advertising and the way that the internet is designed, because they want those dopamine circuits firing as fast as possible, because that's what keeps your attention. So that can become a really big problem. So that's the first problem. The second problem is that, as I mentioned, we're all social beings, and that comes with, social interactions are really complex and often good, but also there's I'm not as good as you are because I'm seeing you and I'm assuming that you have a better life than I do phenomenon, which has always been there, has been there throughout history, and anytime we get together in a social group is there. But because social media amplifies the number of interactions and the type of interactions, and interacting with strangers, that the negative pieces of that have really spiraled. So the internet can be, and also truth is, a sort of spurious thing. At times on the internet, you don't know what things are true and what things are not true. It's sometimes very, very hard to tell, especially in the age of AI. So all of those things are really, really complex. We know that the prevalence of symptoms of depression and anxiety have gone up in our world, in all age groups, and particularly for young people. So I think the counter to that is education. And talking about how to use the internet, how to interact with social media, talk to our young people about that, talk to the young people in your lives about that. If they're, ask them what they're looking at, ask them to, if they're in your family, or close relationship, ask them to share with you what they're seeing, talk about the topics that they're interested in and that they're looking for on the internet, or what's their friend group talking about. I think that can be a really important piece to it, and piece to recognizing that, and balancing time.
Yeah.
Which was your first comment, right? The time on anything, whether it's whether it's the internet, or whether it's something else that's keeping a young person from engaging in a variety of activities.
I believe you made a comment too about just getting outside.
Just getting outside.
Yeah.
Absolutely.
Yeah.
Yep.
Yeah. I have a different question.
Yes.
My watch every day tells me to take time for mindfulness. You talked about that briefly on here, but give me an example of mindfulness.
Oh.
Maybe you can
okay,
make
great
one up
question.
or something.
Yeah,
Just
absolutely.
because it's
absolutely.
still sort of fuzzy in my mind exactly what it is.
Yes. So the idea of mindfulness, the core idea is being in the here and now. And so an example of what we would do in a group to illustrate that is to take, and we're in Hershey. So for all those folks online, we're in Hershey. So take a chocolate kiss and put it in your mouth and let it melt. And observe everything about that. If you can eat chocolate. Don't do this if you're allergic to chocolate.
Oh, depressive.
Something else if you're chocolate. But it's observe every sensation, the taste, the feel, what happens. And so then you spend a few minutes just focused on that one thing. That's mindfulness.
Okay.
So it's the idea of focusing on the here and now, which stops the brain from the what ifs of the future and the regrets of the past,
Yeah.
but coming to that present. And that's why I likened it to, a series of a group of other practices that include that feeling, whether it's meditation, prayer. There are elements of musical practice, singing in a choir, or other musical endeavors, other artistic endeavors that can also capture that being in the moment feeling. Good question. Also,